Hello, friends. This is Rakesh Jain, and I'm looking forward to having a deep conversation with you regarding the complex issue of, yes, benzodiazepines. Are they good? Are they bad? Or perhaps is there another way to look at them? So, where exactly do you stand on the issue of benzodiazepines with our patients? I'm in the state of affairs with the current use of benzodiazepines in the country. As you can see, there's some real reason for concern. Emergency room visits that are related to benzodiazepines, accidental and intentional overdoses, are a real concern. There is simply no doubt at all that benzodiazepines have played a significant role in the growing challenges we have in the country. And you will probably notice that there are no licensed indications for prescribing benzodiazepines for long periods of time. But having said all that, there is genuine controversy in the community regarding benzodiazepines for a variety of reasons. This is why painting benzodiazepines as all good or all bad is just a recipe for disaster. As you can see, benzodiazepines actually are quite effective for the treatment of many disorders, particularly anxiety disorders. And they often work when other medications have failed. So, is it really legitimate to deny such patients treatment with benzodiazepines just because the community has turned against this class of medications? Therefore, I suggest the following. Let there be no doubt, decades of experience has taught us that benzodiazepines, in situations where other medications haven't worked, can often be very helpful, and many patients benefit preferentially from them. And don't abuse them, and use them safely for prolonged periods of time. This is a fact of life. Similarly, another fact of life is that we cannot ignore the recent data emerging from the addiction literature and from emergency room settings and law enforcement and overdose databases. No, there is a problem. So now that we have two opposing things, what is the clinician to do? Perhaps the first thing to do is not to frame any conversation along the lines of automatically benzos are great or benzos are terrible. This kind of thinking is fundamentally flawed and not good clinical practice and unnecessarily harmful to patients. What then is the solution? And this is what we propose. We propose that the risks versus benefits of benzodiazepines, both in the short and long run, should be something we clinicians are aware of, and that in consultation with our patients, we make a final determination. The final determination really isn't automatically giving benzodiazepines to every patient who walks in and asks for it, but by the same token, denying patients where it is an appropriate intervention in many ways is medical malpractice. And certainly, medical knowledge evolves over time, and the arrival of new data and with gathering experience, we will do better. But for the time being, let's be aware that the risk-benefit ratio is what a thoughtful clinician thinks about, carefully determines, and only then takes an action regarding benzodiazepines. Knee-jerk reactions on this complex issue are to be avoided. It may be important for us to remember that benzodiazepines actually do have a number of pharmacological benefits and have a number of therapeutic uses, often in situations where other medications are simply not as effective. Now, most certainly, adverse experiences often become a challenge. And because we're talking primarily about psychiatry, there's no question benzodiazepines can be very good anxiolytics and can diminish aggression in certain groups of individuals. That's all good, isn't it? Of course, the downside, besides obviously abuse and diversion, is benzodiazepines can also induce states of indifference, retreat from reality, flattening of affect, and particularly in combination with opioids and alcohol, truly increase the risk of very bad outcomes, including obviously death. Continuing our conversation, looking at some of the positive attributes of benzodiazepines. Cost is often low. Availability, well, widely available. Often symptom relief can be obtained quite rapidly with benzodiazepines. And this is perhaps the major rub point in psychiatry. For very many patients, it often is the only or often the most optimum effective therapy. This challenges us, doesn't it? This is why we often get caught in this mental conundrum. Do I offer benzodiazepines or do I not? Now that we have looked at some of the positive attributes, it's really important that we be aware of some of the short and long-term challenges with benzodiazepines. Obviously, sedation, cognitive difficulties, sometimes induction of depression, emotional blunting. There is some worry about neurodegeneration with chronic use, and of course, adverse events in elderly can be a challenge. There can be a higher degree of falls in the elderly. And of course, the one topic that's been in wide societal conversation about benzodiazepines is the risk of drug abuse and dependence. It is important to highlight that the majority of individuals who use benzodiazepines under the care of clinicians are not abusing the medication, nor do they tend to increase the dose. Some definitely do, but the data shows the majority do not. There are some known risk factors in patients that could alert us that they might be at higher risk of benzodiazepine misuse, abuse, dependence. And here is a nice slide that puts together some information regarding factors that increase the risk of drug abuse and clues to possible drug abuse in patients. I won't go through this in detail, but at your convenience, you're welcome to pause this video so that you can fully absorb the information contained in this slide. Hopefully by now, I have somewhat convinced you that taking a harsh stance on benzodiazepines in either direction is not in the profession's best interests, nor in the best interests of our patients. I think benzodiazepines call upon us to take a very nuanced and thoughtful approach to prescribing them. Where do we offer them? Where do we not offer them? If there is one word that should guide our thinking and practice of benzodiazepines, I think that one word is moderation. Okay, let's make it two words. Thoughtful moderation. There is so much we can do to create greater safety with the use of benzodiazepines. And here I have a slide with 4 suggestions. Number 1, titrate doses, not too aggressively, thoughtfully. Number 2, observation. And in such patients, closer observation and quicker follow-up would be the right way to go. The third thing we could do is proper screening. If there are high-risk patients, well, certainly exclude them or find other ways to make sure that therapy is offered with a benzodiazepine very carefully, perhaps a very small dose, perhaps very few pills at a time, perhaps have a family member watch for it. And then, of course, the greatest of all elements is patient education. Telling the patient that this is a partnership between us and them, that there is an upside to this class of medications, there's a definite downside, and that it's going to be the partnership, the quality of it, the closeness of it. That is what's going to determine long-term success with this medication. So as we near our brief time together talking about this complicated issue, I hope it's becoming clear that benzodiazepines are neither a good nor a bad idea. They're both. It just depends on the patient. And it's our job to determine which way we will go with a specific patient. And I have nothing but confidence. With thoughtfulness, we can do it. Thanks very much for being with me, and goodbye for now.